In medicine, iron overload indicates accumulation of iron in the body from any cause. The most important causes are hereditary haemochromatosis, a genetic disorder, and transfusional iron overload, which can result from repeated blood transfusion. Signs and symptoms: organs commonly affected by hemochromatosis are the liver, heart, and endocrine glands. Hemochromatosis may present with the following clinical syndromes: cirrhosis of the liver, diabetes due to pancreatic islet cell failure, cardiomyopathy, arthritis, testicular failure, tanning of the skin, joint pain and bone pain. Causes: the causes can be distinguished between primary cases and less frequent secondary cases. People of Celtic, British, and Scandinavian origin have a particularly high incidence, of whom about 10% are carriers of the gene and 1% suffer from the condition. Primary hemochromatosis: although it was known for most of the 20th century that most cases of hemochromatosis were inherited, they were incorrectly assumed to depend on a single gene. The overwhelming majority actually depend on mutations of the HFE gene discovered in 1996, but since then others have been discovered and sometimes are grouped together as non-classical hereditary haemochromatosis, non-HFE-related hereditary haemochromatosis, or non-HFE hemochromatosis. Most types of hereditary hemochromatosis have autosomal recessive inheritance, while type 4 has autosomal dominant inheritance. Secondary hemochromatosis: severe chronic hemolysis of any cause, including intravascular hemolysis and ineffective erythropoiesis, multiple frequent blood transfusions, which are usually needed either by individuals with hereditary anemias or by older patients with severe acquired anemias such as in myelodysplastic syndromes, excess parenteral iron supplements, such as what can acutely happen in iron poisoning, excess dietary iron. Some disorders do not normally cause hemochromatosis on their own, but may do so in the presence of other predisposing factors. These include cirrhosis, steatohepatitis of any cause, porphyria cutaneosa, prolonged hemodialysis, and post-portocaval shunting. Diagnosis: there are several methods available for diagnosing and monitoring iron loading, including serum ferritin, liver biopsy, HFE, MRI. Serum ferritin testing is a low-cost, readily available, and minimally invasive method for assessing body iron stores. However, the major problem with using it as an indicator of iron overload is that it can be elevated in a range of other medical conditions unrelated to iron levels, including infection, inflammation, fever, liver disease, renal disease, and cancer. Also, total iron binding capacity may be low, but can also be normal. The standard of practice in diagnosis of hemochromatosis was recently reviewed by Pietrangelo. Positive HFE analysis confirms the clinical diagnosis of hemochromatosis in asymptomatic individuals with blood tests showing increased iron stores, or for predictive testing of individuals with a family history of hemochromatosis. The alleles evaluated by HFE gene analysis are evident in 80% of patients with hemochromatosis. A negative report for HFE gene does not rule out hemochromatosis. In a patient with negative HFE gene testing, elevated iron status for no other obvious reason, and family history of liver disease, additional evaluation of liver iron concentration is indicated. In this case, diagnosis of hemochromatosis is based on biochemical analysis and histologic examination of a liver biopsy. Assessment of the hepatic iron index is considered the gold standard for diagnosis of hemochromatosis. Magnetic resonance imaging is emerging as a non-invasive alternative to accurately estimate iron deposition levels in the liver as well as heart, joints, and pituitary gland. Screening: family members of those with primary hemochromatosis should be screened to determine if they are a carrier or if they could develop the disease. This can allow preventative measures to be taken. Screening the general population is not recommended. Treatment: routine treatment in an otherwise healthy person consists of regularly scheduled phlebotomies. When first diagnosed, the phlebotomies may be fairly frequent, perhaps as often as once a week, until iron levels can be brought to within normal range. Once iron and other markers are within the normal range, Phlebotomies may be scheduled every other month or every 3 months depending upon the patient's rate of iron loading. For those unable to tolerate routine blood draws, there is a chelating agent available for use. The drug deferoxamine binds with iron in the bloodstream and enhances its elimination via urine and feces. Typical treatment for chronic iron overload requires subcutaneous injection over a period of 8 to 12 hours daily. 2 newer iron chelating drugs that are licensed for use in patients receiving regular blood transfusions to treat thalassemia are diphrasiox and viriprone. Prognosis: a third of those untreated develop hepatocellular carcinoma. Affected individuals over age 40 or who have high serum ferritin levels are at risk for developing cirrhosis. Significant problems occur in around 1 in 10. Epidemiology: it is most common in white people and occurs in 0.6% of the population. Men who have the disease get symptoms from too much iron 24-fold more times more often than women. Terminology: historically, the term hemochromatosis was initially used to refer to what is now more specifically called hemochromatosis type 1. Currently, hemochromatosis is mostly defined as iron overload with a hereditary primary cause, or originating from a metabolic disorder. However, the term is currently also used more broadly to refer to any form of iron overload, thus requiring specification of the cause, for example, hereditary hemochromatosis. Hereditary hemochromatosis is an autosomal recessive disorder with estimated prevalence in the population of 1 in 200 among patients with European ancestry, with lower incidence in other ethnic groups. The gene responsible for hereditary hemochromatosis is located on chromosome 6. The majority of hereditary hemochromatosis patients have mutations in this HFE gene. Hereditary hemochromatosis is characterized by an accelerated rate of intestinal iron absorption and progressive iron deposition in various tissues that typically begins to be expressed in the 3rd to 5th decades of life, but may occur in children. The most common presentation is hepatic cirrhosis in combination with hypopituitarism, cardiomyopathy, diabetes, arthritis, or hyperpigmentation. Because of the severe sequelae of this disorder if left untreated, and recognizing that treatment is relatively simple, early diagnosis before symptoms or signs appear is important. In general, the term hemosiderosis is used to indicate the pathological effect of iron accumulation in any given organ, which mainly occurs in the form of hemosiderin. Sometimes, the simpler term siderosis is used instead. Other definitions distinguishing hemochromatosis or hemosiderosis that are occasionally used include: hemosiderosis is hemochromatosis caused by excessive blood transfusions, that is, hemosiderosis is a form of secondary hemochromatosis. Hemosiderosis is hemosiderin deposition within cells, while hemochromatosis is hemosiderin within cells and interstitium. Hemosiderosis is iron overload that does not cause tissue damage, while hemochromatosis does. Hemosiderosis is arbitrarily differentiated from hemochromatosis by the reversible nature of the iron accumulation in the reticular endothelial system. See also, human iron metabolism, references. Further reading, Louis, Adrienne C. Outen, Karen E. Chapter 8 The Iron Metalome in Eukaryotic Cells. Inborn C., Lucia. Metalomics and the Cell. Metal Ions in Life Sciences 12. Springer doi, 10.1007 over 978-94-007-5561-18. ISBN A978-94-007-5560-4 Electronic book ISBN 978-94-007-5561-1 ISNA 1559-0836 Electronic ISNA 1868-0402, Pradot, S. Lacour, J.P. Degeville, C. Castanet, J. Buta Copyright, P. Orton, J.P. Bronze Baby Syndrome. Annals de Dermatologie et de Venéreologie 121, 568 €70. PMIDA 7755316 External links, ironoverload.org, haemochromatosis.org, UK Haemochromatosis Society, haemochromatosis.org.au, Haemochromatosis Society of South Africa, Canadian Haemochromatosis Society, Gene Review NIHUW entry on HFE-associated hereditary hemochromatosis, iron overload, hemosiderosis, hemochromatosis, Gene Review NIHUW entry on TFR2-related hereditary hemochromatosis, Gene Review NIHUW entry on juvenile hereditary hemochromatosis, Gene Review NIHUW entry on aceruloplasminemia, Feriscan, MRI-based test to measure iron overload.